So let's go to our next master, that's Dr. Sathyan. He's a renowned glaucoma surgeon. He's the president of the Glaucoma Society of India. Dr. Sathyan will speak to us on YAG PI without Pilocar.
First of all, my sincere thanks, and always been a pleasure to be in KSOS meetings. How many of you do YAG PI here? Can you just raise your hands? Oh, that's wonderful. Then my talk is really fulfilled. So, how many of you do use Pilocar? So, all of you are getting Pilocar. How many of you are not getting Pilocar? Okay. So, how many of you have the problem of patient complaining, or probably many times we don't even ask whether the patient has a problem or not? Do you ever ask whether the patient has a headache after applying Pilocar? Okay, only one of those. Okay. So definitely most of the patients, they do have a headache with the Pilocar application, or they complain about something or the other, like they feel everything is dim, whatever it is. So it is important to use Pilocar in when you are planning for a YAG peripheral iridotomy, where you want really stretch out the iris so that iris becomes thinner and you can start seeing the crypts better to do the YAG PI much easier. So, but then you have this problem of severe headache and also other associated problems, and also availability of the Pilocar only from, I'm not sure whether I can say the trade name. The Pilocar from FDC is good, but some of the other Pilocar doesn't constrict the people as good as what you see. So once you have the crypts like this in your slit lamp examination, is it really you want to constrict the people using the Pilocar? Many times you really may not be doing that, or may not be really requiring to do that. So, but then definitely yes, we have to constrict. But then you see this, all of us know there is a consensual reflex. When you show the light in one eye, the other eye also goes in for constriction. But what is the problem? See here, the light is shown, direct light, but there is a ill-sustained people. So you really may not be able to do a proper iridotomy when the people is ill-sustained. But instead, you go and put the torchlight in the other eye, the people goes for a constricted position nicely. So you keep showing the light in the other eye, then people will be really constricted well. This is instead of 2 millimeters, it will be around, instead of 1.5, it may be around 2 millimeters, but it is enough for you to really see the crypts and do the YAG peripheral iridotomy without usage of Pilocar. It is one of the most simplest thing which you can do. The second part is, I'll just show you this again. All of you know this blue light. The blue wavelength light is picked up by something called as there are different RGCs, retinal ganglion cells. There is something called as a IPRGC, that is called as the intrinsically photosensitive retinal ganglion cells. These IPRGCs picks up the blue light specifically at the 475 nanometers. So the advantage of this blue light is, once it is shown, it constricts the pupil and sustains it more than what you show with your white light. So I'll just show you the video here. So this is the white light, and then you can see this is the regular white light. You can see the pupil is getting constricted. The other eye also you can see the consensual is working. But then you see, I will be showing the blue light. See, when the blue light is shown, the pupil really goes in for a nice 1.5 mm constriction, and also it sustains longer. That is the action of IPRGC over the blue light. So it sustains for quite some time till you complete your YAG peripheral iridotomy. So there is nothing much more to show that. So I have put in a small blue light illuminator over the slit lamp. It's just like a regular clip where we hang our clothes. Just put the clip in your slit lamp. Today we have all these LED lights, very easily available, very cheap, 1,000 rupees, 1,500 rupees, it is available. You just put and show this, and then it is very easy. You can see the pupil is completely small. So I thought I'll just share this video because these are very practically, and most of the time it is done by most of the doctors. So I thought it may be useful for you. Thank you.
Thank you, Sathyan sir. Such innovations are what makes the ordinary person different from the extraordinary.
Anything specific?
One question. Is the blue light more comfortable to the patient than white light, or is it all the same?
It is not comfortable, first of all. Only thing is, if you are going to buy more luminance, for example, this particular light, my staff was complaining about, it is more heat generating because it was more close to the eyes, but you can keep it little away also. So that is not a problem. Blue light is not very uncomfortable. It is something like a dark. The white light is much more uncomfortable than the blue light, and it sustains for longer duration because of the IP-RGC activity. So that is very interesting actually. Recently we are doing the study now on the IP-RGC, which is having lot of effects. Especially all our circadian rhythm is completely controlled by the IP-RGC. So if the IP-RGC is not working properly, so there is a, if you just go through the publications, when the IP-RGCs are not there, what really happens is patient goes in for a obesity with lot of gastrointestinal problems, anxiety, depression. So there's a nice article on that where you don't have the IP-RGC, patients how they go through, and how you treat is giving them the melatonin for the circadian rhythm. There's very interesting articles are there. So it's nice to see how the IP-RGCs are working. Thank you.
Post VR surgery, shallow AC, does it work? Your concentral reflex with the light in the other eye.
You are talking about constriction of the pupil, or what exactly you mean
many
by?
Many a time you have this post VR surgery patients going for shallow AC and raised IOP, and you do a YAG PI.
Right. Okay.
In such cases, does it work? Because the patient might have used cycloplegic for a long time. We have stopped it a couple of days back, but they have used it for a long time, and the pupil is sort of unresponsive.
See, once the pupil is not having any adhesions, and once the consensual is really working, it should work without any problems. But having said that, I haven't tried on this kind of cases. But once there is no Sinec A, then it should really work. There is no change in that. So it's a pupillary pathway anyway. The pupillary pathway, the light reflex is again completely controlled by the IP-RGC.
Okay, thank you. Any questions from the floor? Thank you, Sathyan.